2, 1. Sir, we are live now.
A very good evening, ladies and gentlemen. This is Dr. Harsh Chaturvedi, Vice President, Medical Affairs and Clinical Research of Pulse Pharmaceuticals, welcoming you to a very exciting evening on behalf of Pulse, also on the behalf of OrthoTV. Today, the talk deals with the new era in the management of osteoarthritis, the evidence mapping. We are mapping the evidence, we are showing the evidence of new emerging products, which do take us away from the routines of analgesics and NSAIDs and have the ability to take care of the disease right at the onset, right at the very beginning. Also, which can be used as adjuvants, which help us augment the therapies, at the same time reduce the side effects or the risk associated with more conventional therapies. And last but not the least, they may have a scope in delaying the joint replacement or the requirement for the joint replacement. I'm hoping all of this will emerge from today's talk, where we have two very knowledgeable speakers with us in Andrea, who joins us from Spain and works with Bioiberica, and Dr. Jagan Reddy, who joins us from Hyderabad. But before I introduce them further and talk about them, I have, I have a brief presentation for you, which deals with my organization. I'll be sharing my slides with you in a minute so that I give you a complete picture of my organization. I'm struggling. Yes, I hope my slides are visible.
Yes, sir.
Yeah. So as I said, I represent Pulse Pharmaceuticals, and the program very aptly entitled The New Era in the Management of Osteoarthritis, Evidence Mapping. To talk briefly about Pulse, Pulse is a patient-centric, innovation-driven integrated pharmaceutical company with inclusive growth model. We have been in existence for past 26 years with presence across India and also across the emerging markets. We also have started making forays in the European and the US markets. We have a world-class R&D and a manufacturing setup at Hyderabad and a few other places in India. We have strong leadership and operational teams across all business functions. These business teams, they cater to orthopedics, they cater to neuropsychiatry, pediatrics, gynecology, and nutrition as well. We lead in the space of nanopharmaceuticals and drug delivery research. We have strong presence in medical nutrition, as I mentioned earlier, through our sister concern, which is Pulse NutriScience. And we are also foraying into immunocell therapeutics by developing novel CAR-T technologies. For this, we are in regular communication, and we have associated with the premier federal government institutions like Center for Cellular and Molecular Biology. Our business philosophy is we create customer value through high quality differentiated products, services by using advanced and patented technologies. We try to exploit the limitations in the pharmacokinetics principally. You'll appreciate it's not always possible to deal with pharmacodynamic aspects where you're trying to reduce certain side effects. But yes, where there are pharmacokinetic limitations, especially in terms of absorption and the bioavailability, yes, we are foraying in those principally. We ensure that the right quality of medicines, the medicines we export globally, are the ones which are used by the Indian patients as well. This is about our manufacturing setups. Our new manufacturing facility, which is coming up at Genome Valley at Hyderabad. We have an existing manufacturing facility in North India in a place called Roorkee. We also have Pulse Advanced Research Center, where about 120 scientists work overtime with a focus not only on developing nanotechnologies, but also on the development of API or active pharmaceutical ingredients, where the focus is also analytical development and the regular formulation development. Pulse NutriScience, which has the R&D and the manufacturing facility, is currently based at Genome Valley at Hyderabad. They take care of nutritional needs. We basically specialize in providing high protein supplements for various conditions. We also have a R&D facility under construction at ICICI Knowledge Park, which is going to be functional in next 2 months. So, which is more elaborate and more state of art than our existing facility. We have been recipients of awards like Vidurg Bharati Award, Hall of Fame Award, National Award for Quality Excellence, and India's Small Giant, India SME Forum, which is associated with NDTP. So these are a few things which we have. And today we have the pleasure of having Dr. Jagan Reddy, FRCS, is trauma and orthopedics surgeon, with us, who will be talking to us about his experience with the use of the knee flex combination. To tell you in brief, Dr. Reddy has done his MBBS from Osmania Medical College at Hyderabad. He holds MRCS and FRCS membership of Trauma and Orthopaedic Association. He holds a diploma in sports medicine from Royal College of Surgeons at Edinburgh. He is a postgraduate diploma in health sciences from the University of Central Lancashire, Preston at UK. He holds honorary membership of the Royal College of Surgeons of Edinburgh, British Indian Orthopaedic Society, British Orthopaedic Association, Indian Orthopaedic Association, and Indian Medical Association. Apart from this, he actively participates in clinical research with Warwick and Oxford universities and has won a research award from the Oxford and an honorary gold medal in 2014. Dr. Reddy is currently practicing as a senior consultant in orthopedics, joint replacement, and sports medicine surgery at Care Hospitals based at High Tech City in Hyderabad. With this, I welcome you, sir. We also have Andrea with us, who is a biotechnologist and has a MS and MBA and has extensive experience in pharmaceutical industry. She has earned her bachelor's degree in biotechnology from University of Barcelona in 2019. She did her master's in medicine, health and healthcare system from University of Barcelona in 2020. And she did her master's in business administration also from University of Catalonia in 2023. She is well versed in many international languages, including Spanish, Catalan, French, apart from English. She has earlier worked in the sales and marketing and regulatory affairs for a past organization. She is the R&D project manager, human health, for Bioiberica, Barcelona, Spain. I welcome you, Andrea, to this very exciting evening. First, we are going to be listening to you. Especially, I believe you are going to emphasize on the mobili and the Colavint, the two ingredients which are there in the knee flex. And later on, we'll move on to Dr. Jagan Reddy and learn from his experience of using this combination. With these words, I thank you, ladies and gentlemen. But before I invite Andrea to share her knowledge with us, I will request my colleague to play a corporate video of Pulse Pharmaceuticals. Can we have the video, please? We need to increase the volume, I guess. Can we have the volume, please? We can't hear. Hello, we can't hear. Can we have the volume? Although we seems to have some problem with the volume. Can you hear me? I think there was a small problem with the volume of the video. Nevertheless, we'll take it later. First, we move on to our first speaker for the evening, Andrea Terradillos, who is, as I mentioned, from Bioiberica and is involved in the human research. So it is over to you, Andrea, to talk to us about Colavant and Mobili. I'm sure you'll be talking about the other two also, but the emphasis, will, I believe, is on these two products. It's over to you, Andrea.
Thank you for the presentation. It's a pleasure to speak to you. Please, can you kindly confirm if you can see my screen?
Yes, we can.
Yeah?
Yeah.
Perfect. So as Dr. mentioned, I'm going to speak about collagen, which is our native type 2 collagen, and also Mobili, our matrix of hyaluronic acid. As you may know, collagen it's protein in the extracellular matrix of connective tissues. There are 28 types of collagen, but actually there are two types that are available commercially talking. One of them is type 2 collagen, which is the main structural protein in the cartilage. It provides tensile strength and toughness to the tissue. Our molecule is the native type 2 collagen, also called andenator type 2 collagen, and it's the biologically active form. It means that it maintains the triple helix of the polypeptide chain. This collagen is extracted from chicken sternum under GMP compliance, either for FDA and also for EMA, for Europe. And this molecule is quite relevant because it has a mechanism of action called the immune-mediated mechanism called oral tolerance. This mechanism, as you know, when there's a degradation of the cartilage, some small fragments of collagen are released to the synovial liquid. These small fragments generate an immune response that generate interleukins that they stimulate the degradation. So when you administer collagen, as it's native collagen, it reaches the Peyer's patches in the small intestine, and it is recognized by our immune system as an inner molecule. Through different mechanisms of immune system, this native type 2 collagen helps in the generation of endogenous collagen in the joint, meaning that there's a suppression of the immune response and no other fragments are generated. So there's no inflammatory response of the immune system, meaning that there's no cartilage degradation, and therefore the cartilage is protected and less pain and inflammation occur. This doesn't happen. Doesn't happen with hydrolyzed collagen. It has a different mechanism of action, as it consists of small peptides. Another relevant differentiation is that native type 2 collagen only needs a really low dose of only 40 milligrams to have effects, while hydrolyzed collagen needs 10 grams. That is a huge amount to take into a pill. We have different studies, either preclinical and also clinical, that show the effect of native type 2 collagen. Regarding the preclinical studies, we wanted to check how it was beneficial for mechanical hyperalgia, thermal hyperalgesia, and mechanical sensitivity through different tests. As you can see, with really low doses of native type 2 collagen, we have mechanical notions. Also, there's a reduction, a significant reduction in articular pain. And also, there's in this test, that it's electronic bond rate test that you may know, mechanical sensitivity. Therefore, the efficacy of collagen in reducing pain was higher as dose was lowered. So lower doses, better effects. And there's a general improvement in motor activity and also in incapacitants. Moreover, in this study, as I mentioned to you, there are many different inflammatory cytokines. In this case, we wanted to check if there was an effect. And we measured CTX2, that is a biomarker for cartilage degradation. And as we can see, the concentration decreases while we apply, when we administer collagen. Therefore, these results indicate that there's a decrease in pain, and also there's a protective effect of the cartilage evaluated by different biomarkers, in this case, CTX2. Regarding clinical studies, we have performed two different ones, one observational and one randomized. In this first clinical study that I'm going to explain to you, we wanted to check how was effective on the symptoms and also on the determination of different biological markers of cartilage degradation. So in this case, we treated patients with acetaminophen, which will be equivalent to paracetamol. And also we had a different group with native type 2 collagen together with acetaminophen. In these first results, we determined WOMAC, that it's a questionnaire fulfilled by patients, in which we evaluated pain, physical function, and effectiveness. As you can see below, there was a reduction, a significant reduction in woman total score between baseline and the end of the study, that it was 3 months, having an improvement on pain and also on quality of life and also in function. Moreover, we wanted to check these values were confirmed, and we did the BAS score. In this case, we also obtained significant differences. And in this case, there was a decrease in the BAS score, having less pain. And there's a huge higher significant difference between acetaminophen and collagen, the group placebo and the group together with collagen. Regarding the biomarkers of cartilage degradation, we can also see that there's an improvement, decreasing this cartilage degradation and therefore protecting the cartilage. So we can say that native type 2 collagen together with acetaminophen has a superior effect than only acetaminophen for symptomatic treatment of patients with knee osteoarthritis. In another clinical study, we had different groups. In this case, we wanted to check how it affected osteoarthritis, and mainly of hand, hip, or knee. In this case, we had two groups, glucosamine and chondroitin sulfate, that is the standard treatment for osteoarthritis, and also the second group with collagen, glucosamine, and chondroitin. In this case, we evaluated the effects for 1 year. As I mentioned, CTX2 is the biomarker for cartilage degradation. So we wanted to check how it evolved during this whole year. And we could find that there were significant differences between the group with glucosamine, chondroitin, and native type 2 collagen versus only glucosamine and chondro. And also, it's quite relevant that once a year it's passed, there's a regression in the group without collagen. So we suggest that there's a protection of the cartilage when you administer the standard treatment together with collagen. Also, we wanted to check the progression of the disease from the radiological point of view in patients with hand arthritis. We saw that there's a lower progression of the disease. Therefore, native type 2 collagen together with glucosamine and chondroitin sulfate reduces pain in terms of WOMAC and BAS. Also, there were lower values for biomarkers CTX1 and CTX2, which are cartilage degradation biomarkers. And from the radiological point of view, we see that there's a reduced progression of the disease. So basically, collagen is a native type 2 collagen that reduces joint pain, stiffness, and improves physical function. We see that there's less cartilage degradation. It's effective at a really low dose of only 40 milligrams. And it helps with the progression of the diseases. We also wanted to mention that it's relevant that it maintains the biological active form, as it's a way of having the immune-mediated oral tolerance, which allows the decrease of the cartilage degradation and it helps as it's recognized as safe in our body. And now let's move on to the other ingredient, which is Mobility. Mobility is a hyaluronic acid matrix that has demonstrated better efficacy than fermented or extracted hyaluronic acid. It is also extracted from animals, from biologically derived molecules, and it helps in improving joint mobility, reducing synovial effusion, and also increases muscle strength of the individuals that take it. We did some in vitro studies to check, for example, PGE2, which is a cell catalase mediator. And we realized that there was a huge decrease once we administered Mobility. Therefore, there's less inflammation and less degradation of the inner molecules. In another study, we wanted to check also in vitro with cultured myocytes if there was an improvement in muscle health and if we could protect from sarcopenia. And we saw that there's an improvement in myocyte hyperplasia and proliferation, and also an 80% difference in myocyte differentiation. Therefore, Mobility promotes muscle health. In this same study, we wanted also to check if there was a decrease in muscle atrophy, muscle damage, and muscle apoptosis. And in all cases, it was a significant decrease of 40% in the case of muscle atrophy. We did all these studies determining different biomarkers, such interleukin beta and different specific indicators. As I've probably mentioned, Mobility is absorbed in the intestine, in the duodenum. 38% it's absorbed there. And the molecule of Mobility, it's a matrix which contains hyaluronic acid along with polysaccharides and collagen peptides. Therefore, the combination of all the ingredients has a higher effect. For Mobility, I'm going to mention two different clinical studies that we did, in which we wanted to check if there was change in pain intensity measured, as well as the VAS score, a visual analog scale. And in this case, we had three different groups: paracetamol, which was the standard treatment, and also we wanted to check Mobility at 40 milligrams and Mobility at 80 milligrams to check if it was dose dependent. All patients had osteoarthritis. And the results, the main results, is that patients taking 80 milligrams had a faster pain reduction and had significantly lower values at 3 months compared with patients that were taking acetaminophen, paracetamol. Also, at only 40 milligrams per day, we had lower pain values. And this supplementation of Mobility resulted in a significant decrease on the number of patients with synovial effusion from the first month of treatment until the end of the study. So we can say that hyaluronic acid is safe and effective in patients with knee osteoarthritis. It relieves knee pain and also reduces the consumption of analgesics. And in the second study, we also wanted to confirm this kind of results. So we compared placebo versus Mobility at 80 milligrams. In this case, we did a randomized double-blind study, and we checked the joint and muscle function in patients with mild knee pain. It means that they had osteoarthritis. So the main outcomes were the muscle function measured by a psychokinetic test, and also the synovial effusion by echographic evaluation. As you can see here, there's a significant increase in muscle peak torque in males, being more than 20% in flexion. Also, there's a significant increase in muscle total work, being at 42%, so quite a big difference. And also we had a significant increase in muscle mean power of 48% in the case of flexion and 48% almost in extension. And lastly, we determined some biomarkers, and we saw that there's a reduction in synovial effusion. Therefore, all results show that Mobility helps in the reduction of the symptoms and can improve all impairments in the affected knee muscle strength and reduces synovial effusion with significant clinical results. I wanted to mention that Mobility also has a really low concentration for actin. It's only 80 milligrams, that it has been approved by EFSA, the European Food Safety Authority, and that it has received the generally recognized as safe status by FDA. Also, we did safety studies in which we showed that there are no adverse events and that it is safe for human consumption. And we are carrying out different clinical studies to show the evidence of Mobility, and we will be able to provide you further details. So we have to mention as well that it's a matrix. Don't forget that it contains hyaluronic acid, polysaccharides, and collagen peptides, and that it has all these different features. Thank you very much. And if you have any question at the end of the presentation, you can for sure ask me.
Thanks, Andrea. We'll be taking questions later after Dr. Reddy's presentation. But I must say it was very informative what you talked about. We'll take it up later. I first move on to Dr. Jagan Reddy.
Yes.
We are so keen to learn from your experience with the combination of knee flex.
Yes.
Where and how to use, and what efficacy to expect. And certainly, I would like to, take up any adverse events which you have seen with it. and so establish the safety and efficacy of the combination.
Yes.
What do you think?
Just thank you, Pulse Pharma, for giving this opportunity. I'm going to talk. I have a brief presentation on the combination of these knee flex drugs. First, I will go through this. Andrea has mentioned in depth about each molecule and what is the mechanism of action. So I will go briefly about all these combinations and why we need a combination of drugs. And I will discuss one or two cases of my own experience with this knee flex or the new era of medical management of osteoarthritis. So I will share my screen. I think I am audible and my slides are visible, I think.
Yes, sir. Go ahead, please.
Yeah. So my name is Jagan Mohan Reddy. Velpula, I'm from Hyderabad. I trained in Usmania and UK. Presently working in Care Hospitals, Hyderabad, High-Tech City. This is brief about myself. I trained in Usmania and I worked in NHS for 14 years. I was a former consultant in Royal Preston Hospital, Chorley Hospital. I was a lecturer in Birmingham Medical School, did few fellowships, few research work with Oxford and Warwick University. So as you all know that osteoarthritis is one of the disabling disease to the people. So it decreases the mobility of the individuals. As you all know that life is moment is life. Osteoarthritis will limit the movements. Normally it affects any joint, but it affects mainly the lower limb joints like hip joint and knee joint are most commonly affected. Why affected? There are several factors. One of the first common is age related, that is called primary osteoarthritis. This is a brief about the knee joint, which formed by the femur and tibia. You have a nice articular cartilage, you have ligaments, you have meniscus, you have synovial thickening, you have muscles and tendons all around the knee joint, which makes the knee joint. It is a complex joint. You have an articular cartilage at the ends of the bone. This is a femur bone, and the tibia bone, you have the ends, that is called articular cartilage. You will have the damage to the articular cartilage, which leads to the osteoarthritis. What are the prevalence of osteoarthritis in India or in global? There's osteoarthritis around 20 to 30%, but India, in some studies, those showed 60% is osteoarthritis. Most commonly affected joint in India is knee joint. Why? Because we use a lot. From the childhood, we use the knee joint a lot, like using Indian toileting, like customs, going on up and down, or agriculture things. That will cause a lot of stress on the knee joint. That will cause osteoarthritis. It is a multifactorial disease. There are, if you think at a molecular level, you have a cartilage catabolism, means degradation, cartilage anabolism, and osteoarthritis, which increase the catabolism, decrease the anabolism, which leads to joint pain and inflammation. And hyaluronic acid is one of the important factor in the synovial fluid that will decrease, that causes the joint stiffness, synovitis, effusion, and muscle atrophy. This is a brief pathophysiology of osteoarthritis. Initially, they thought osteoarthritis is only inflammatory pathway, but no, there are other two pathways have also added. So one is activation of inflammatory pathway, activation of immune-mediated pathway, and decrease in the hyaluronic acid synthesis in the joint. This all three will increase the catabolism, decrease the anabolism, which results in cartilage degradation, which causes the osteoarthritic progress. As Andrea has mentioned about this, I don't want to discuss in detail about this. It is a molecular pathway. Inflammatory pathways decrease the cyclooxygenase and lipoxygenase pathway. Immune things, it releases the damaged products, and activation of T cells, which increase the catabolism. Hyaluronic acid also decrease the lubrication, muscle atrophy, increase the friction, and which causes the cartilage damage. So osteoarthritis, not only the articular cartilage, the entire joint will be disturbed. Bone, cartilage, muscle, synovial fluid, joint capsules, all will be affected. It's called a whole joint disease. So at present, what are the treatment for osteoarthritis? we have a pharmacological treatment, non-pharmacological treatment, and surgical treatment. Pharmacologicals, normally they give a basic painkillers, NSAIDs, and specific anti-osteoarthritic drugs, hyaluronic acids, or chondroitin sulfate, glucosamines like that. Non-pharmacological is a physiotherapy, exercise, and weight loss. Surgically, there are various options of surgeries available, that is joint preservation surgeries and joint replacement surgeries. Joint preservation is like a HTOs or arthroscopic procedures, cartilage procedures or cartilage transfers, chondrofillers, microfractures. They all come under joint preservation surgeries. Joint replacement surgeries or unicompartmental knee replacements or a total knee replacement like that comes under surgical. That is the last option in the treatment of osteoarthritis. This is one example. If around 40s patient will have osteoarthritis of the knee joint involving the medial, some narrowing of the joint space, but the patient is only 40. So what to do? We have to avoid the surgery in these type of things. So we have to use the other methods like pharmacological methods to control the disease, to control the pain, to increase the movement, increase the mobility. If you bombard with the painkillers, patient will have other adverse reactions like GI tract problems, kidney problems, heart problems, all will come. So you have to be very careful while giving the painkillers. The patient can't have painkillers for lifelong, or at least if you give for 5 years or more, you may have adverse effects. So these nutraceuticals will play a major role in treating the osteoarthritic patients in young cohorts. At present, we have painkillers are there. There are few limitations of the current therapy. One is NSAIDs. Normally, we give diclofenac or aceclofenac or hydrocoxib. They all will have side effects, like cardiac effects, or renal effects, or GI effects, or peptic ulcers may. Hyaluronic acid alone, you can give, they have a absorption problem, or if you give only glucosamine and chondroitin sulfate, they may not affect control both catabolism and anabolism. And the results are also inconsistent. And if you take methyl sulfonyl methyl is a good one, but provides anti-inflammatory effect, inhibition of inflammatory cascade, but you have to give high doses to get a clinically effective with this methyl sulfonyl methyl. And collagen peptides are also available there. It only inhibits effective around 5 to 10 grams of dose. It is a building block of cartilage anabolism. It cannot manage this because it controls the only anabolism, but catabolism is more. So alone peptides will not work. So major limitation is this is only if you give a single drug, it only affects on one pathway. It is not able to control all three pathways like inflammatory pathways, immune pathway, and hyaluronic pathways. So the current, if you give 1 or 2 medications like glucosamines, or if you give only hyaluronic acid, it may not able to control the osteoarthritis. So these are the things. Inflammatory pathways or NSAIDs, glucosamines, rose hip extracts, or immediated ones are the collagens and hyaluronic acids are the one things. So osteoarthritic condition where catabolism is more than the anabolism. There is an urgent need to control the catabolism degradation of the cartilage, and also at the simultaneously you should increase the production of the cartilage. So we have things. One is a native type 2 collagen, hyaluronic acid, boswellia serrate extract, and curcumin long extract. If you combine all 4, you will have a good effective management of osteoarthritis in reducing the inflammation, in reducing the stiffness, increase the range of motion, and decrease the muscle atrophy, and decrease the pain. Patient satisfaction is good, and visual analog score will be good. So this is a colavant, which is a collagen, type 2 collagen, acts through the immune pathway. Andrea has explained in detail about that. It absorbs through the Peyer's patches, inhibits the T cell attacks. And if you give hydrolyzed collagen peptides, which is absorption is there, but it is not immune mediated, it is anabolic, dose will be less, but native type 2 collagen is more effective. It acts through the immune mediated, decrease the collagen destruction. So it is a very safe. It is oral toleration, means if you give orally, well tolerated, absorption is good, it reduces the joint pain, reduce the stiffness, increase the physical function. It also reduce the cartilage degradation biomarkers. It affects at 40 milligrams per dose, and it gives a comprehensive cartilage protection. Other one is aflapine. Aflapine is a Boswellia agba, is acetyl keto bosulic acid combined with the non-volatile oils that will give a good effect to things. Aflapine, which is helpful in reducing the inflammation. So plain Boswellia along with non-volatile oil is aflapine. It is internationally available. It inhibits the 5-lipoxygenase pathway, and inflammation will decrease, pain will decrease, joint stiffness will decrease. This is the pathways. Lipoxygenase pathway suppress the leukotrienes formation, reduces the inflammatory mediators, inhibits the matrix metalloproteases. It reduces the cartilage breakdown. At the same time, it promotes the cartilage formation. So this is a anti-inflammatory action. Selective 5-lipoxygenase inhibition inhibits the inflammatory markers like TNF alpha, interleukin 1 beta, and it is a good cartilage protection. Matrix metalloproteinase inhibition. It is a chondroprotective action. Anabolic effects on cartilage tissue. Significantly reduces the pain within 5 days. This is very safe and high bioavailability through oral and standardized to 20% of AGBA efficacy in Indian populations, and it is available in European countries, and good studies available in Indian patients. Other one is curculife, is a curcumin, is a long extract. It's a novel bioavailability. There are three major types of curcumins: curcumin, D-methoxycurcumin, bis-D-methoxycurcumin. Significantly improved bioavailability in vivo experiments, clinically proven for its enhanced oral bioavailability in comparative human bioavailability studies. Delivers 48-fold higher free curcumin levels in blood versus unformulated curcumins. If you give a unformulated, bioavailability is less. So how it acts? It inhibits the cyclooxygenase pathway, decrease the matrix metalloproteases, reduce the oxidative stress. So decrease the prostaglandin synthesis. It controls the pain and inflammation, reduces the cartilage degradation, which controls the osteoarthritic symptoms and progression. So other one is a mobili, which is called hyaluronic acid. As you all know, it attacks the third pathway, hyaluronic acid pathway. If we give a good supplement, good quality of hyaluronic acid, it promotes the control of osteoarthritis. It is good absorption from the duodenum, 38%, and 22% from the jejunum, and 9% from the ileum. It is a very safe, approved by the European Food Safety, and FDA is approved. It's a very good things. Numerous clinical studies reported that mobili at 80 mg per day supplementation for up to 6 months is safe and well tolerated, which is a natural, patented, clinically proven oral hyaluronic acid formula for synovial joint and muscle health. It's a good absorption from the GI tract. It stimulates the endogenous hyaluronic acid synthesis. It proven efficacy and safety in numerous clinical trials. Significantly, it reduces the synovitis, synovial effusion, and improves the muscle strength. In osteoarthritis, you will have muscle atrophy. Why? Because they won't use it. This stimulates, prevents the muscle atrophy, and increases the muscle strength. And it modifies the expression of genes associated with connective tissue changes and joint pathophysiology. Its safety approved by the European standard societies. So in clinical, combination of the collagen, that is Colavant N2, Aflapin, Mobili, and Curculife. So type 2 collagen, Boswellia extract with non-volatile oil and hyaluronic acid and curcumin, if you combine all this, will have synergetic effect. It controls inflammation, it controls the immune things, it controls the hyaluronic pathway. So all will attack and prevents the progression of osteoarthritis, helps in reducing the cartilage catabolism, increases the cartilage anabolism. There are plenty of studies which has given good improvement, even with the good improvement of outcome of visual analog scores, range of motion, knee outcome scores. If you compare the visual analog scores, the baseline was 6.5. At 2 months, there is a significant, that means 50% of the pain has come down within 2 months if you use the combination of these 4 drugs. And range of motion, very important in the knee, is significantly improve the range of motion. If you decrease the pain, inflammation come down, good muscle power, automatically the range of motion will increase. And compare with the knee outcome scores, significantly improves in the knee outcome scores with this. In conclusion, in my experience with the knee flex, which is a combination of all these 4 drugs, Covalent, which is a type 2 native collagen, is better than the free peptides. Aflapin, which is Agba, which is Boswellia extract, along with the non-volatile oil, plus Mobili, which is hyaluronic acid, and curcumin, all will have positive adjuvant effects in the management of osteoarthritis. The combination not only improved the symptoms and quality of life, and in the future or after using of these things, we can significantly reduce the NSAIDs. We can use without NSAIDs, like simple paracetamol. We can manage the paracetamol, and in combination of this at the beginning, and slowly we can withdraw all the painkillers. Only on this, it will give a good effect. This is the rationale of combination. It attacks, as I told in the beginning, attacks the inflammatory pathways, attacks the immune pathway, and attacks the hyaluronic acid synthesis pathway. So what are the dose is 1 capsule per day before bed, preferably. And duration is minimum 2 months. We should warn the patient that this is not a painkiller. You may not get immediate pain relief with this, as you see with NSAIDs, but with the prolonged taking, you will have good effect with this combination of drugs. As I told in the beginning, I have a few experiences with this. Young patients, this is a protect for us. Young patients, they will come us, and we can't do a joint replacement in young patients, and we have to give alternative things. This is the best way. So oral combination of these drugs, which are safe, and clinical trial shows good improvement in the pain, visual analog score, range of motions, and back to their work, and activity of their daily living is significantly improved. And in the last, as you all know, that end stage is the knee replacement. If they come at certain 60 plus or 70 plus with a grade 4 osteoarthritis, tried all methods, is the last one is knee osteoarthritis. So in my experience, I'm using this knee flex for last couple of years, and we got significant good results, good feedback from the patients, and significantly we can postpone the knee replacement. We can buy time. Young patients, we can wait for 5 years, 10 years, 15 years, so that they can buy the time. Knee replacement can be avoided in young patients. This is not the alternative. This is a supplement, and it helps in controlling the disease, and we can arrest the progression of the osteoarthritis. That's the thing. Thank you.
Thank you, Dr. Reddy, for sharing your experience.
Yes.
It was fascinating listening to you. And the benefits your patients have experienced. So what I gather is it is irrespective of the stage or grade of osteoarthritis, knee flex can be used.
Yes.
It can be used right in the beginning, the first time the patient comes, not with so severe a disease, where it can be the only drug which can be used. Then subsequently, it can be added on to the other painkillers and NSAIDs, and it will also help us both help us reduce the doses of those agents, as well as that will help us curtail or keep a check on the side effects, because NSAIDs, especially, we talk about now, we are more concerned even about the lower GI injury and acute renal issues with the use of NSAIDs. And thirdly, it can be used in a higher grade disease where we can use it for postponing the surgeries. So irrespective of what stage, what grade the patient is, knee flex finds its use.
Yes, absolutely. Yes.
Now, since you have used one of the very pertinent questions which comes up is about the safety profile. Your experience with the safety adverse events, have you seen any, and what they have been in particular with the use of knee flex? First, I'll ask you, and a brief fleeting mention was made by Andrea also. Subsequently, I go to her with the same question. Your experience with the adverse events.
Yeah. And do you want to take? Yeah. In my experience, the knee flex, there is no major adverse reactions like anaphylactic reaction or anything, like no vomiting or diarrhea or things. Only few of them, they said, I don't have any effect with this medication. That is only the side effects I can see. But no adverse effects, which are significant adverse effect, I have not seen. Only thing, the few percentage of 10 to 15%, they may say, I may not have any change with this medication. But 80%, they said, I have some improvement with this medication. So far, I have not seen any adverse effects, significant adverse effects with this knee flex.
How has been your experience, Andrea? Because I saw you have undertaken a year-long study.
Yeah.
Which is a fairly long time. Yes.
Yeah. After carrying out different clinical trials, we've never registered any adverse event, so we can state that it is safe for everyone. There are no major symptoms or any kind of comment that we have received on this product. Yeah.
Okay. Another facet which was very heartening, and but it all at the same time intrigued me, Dr. Reddy and Andrea, there was a mention that mention was brought of sarcopenia. I think a mention was made by Andrea in some of the studies, especially where Mobili was used, if I am not mistaken.
Yeah, you are completely right. Yeah.
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 So how do we see that aspect of sarcopenia?
We realized that we had this product mainly for joint health together with Coleman. And based on research, we realized that it could also benefit in sarcopenia patients. So therefore, we did some in vitro studies that really showed really good results in fibroblasts and also in myocytes. So it's a line we are trying to develop, and probably we will have future clinical trials to guarantee that its efficacy in sarcopenia.
Okay. But Dr. Reddy, I would like to understand muscle atrophy, I'm sure, is a frequent concern and a happening in your patients. And somewhere she is also bringing in sarcopenia. I understand pretty well that there's not much we can do about sarcopenia, apart from probably rehab, exercise kind of thing. And one of the very important things is maintaining hydration, which is particularly important. Apart from that, we have talked about leucins and heard about HMBs and so on and so forth. Now, what she has spoken and what you have seen, I would like to understand from you your take on
Yes.
first with the muscle atrophy there, and then versus sarcopenia. I'm sure you'll be seeing a lot of patients with sarcopenia.
Yes, we have. Previously, we used to call is muscle atrophy, but the last 4-5 years, we changed it as sarcopenia. Mainly the elderly population, the osteoarthritic cohort is elderly people. Elderly people will have not only arthritis, they have multiple medical problems like diabetes, hypertension, thyroid, asthma, some other conditions will have. One of the most precipitating factor for muscle atrophy or sarcopenia is mobility, limited mobility. They have osteoarthritis of the knee joint, shoulder joints. They have all wastings of biceps, quadriceps, hamstring wasting, that calf muscle wasting will be there. They have sarcopenia. So why? Because they have limited mobility. They are not using the muscles. They are not using the joint. This is called disuse atrophy. And also they have nutritionally deficient. They won't take proper balanced diet because of old age, because of lack of availability or care, and because of mobility. So one thing, if you rest, that is a policy. So muscles become atrophy. There are things you can supplement with amino acids. You can supplement with the protein supplements, all their exercise. In my belief, the diet plays one role, but majority is the physiotherapy and mobility. If we get back the joint mobile, the automatically sarcopenia will be controlled, will get back. We can get back the muscle power. We can get back the muscle mass with the mobility only. If we don't move the muscle, whatever you bombard with any supplements, it won't improve. So this medication or any joint supplements like our knee flex, it increases the mobility, not only the knee arthritis. They may have shoulder arthritis, elbow arthritis, or ankle or hip arthritis, all will be affected, not only the knee joint. So all joints will be helps in mobility. And we got mobility is there, it may supplements the increase the muscle mass. So what we recommend to our patients is pain control, inflammatory control, physiotherapy, go mobile, no bed rest, mobility, mobile, and good diet. That will help in increasing the muscle mass, decrease the sarcopenia. And also we assess with the physiotherapist. We will measure the girth of the thigh at the mid portion, girth of the calf, girth of the biceps.
Yes.
And we will assess the progress, how this gentleman or this woman is doing with this medication. So if we can catch it, we can supplement it, we can take the help of dietitian, and we can improve it. That's we will do normally.
So, in a sense, one of the key ways the combination is helping is because of improving the mobility, and that's paramount, in sarcopenia, and that's where the mobility is coming in handy.
That is an additional advantage.
Yeah, that is the additional advantage which is there. And I have a question which has come here is how to incorporate collagen type 2 with collagen peptides. I don't understand what it exactly means.
No, he's asking whether we can give combination of collagen peptides along with.
Okay, sorry. Okay. I think you got it better than me because you have some thoughts on that.
Previous supplements they used to give collagen peptides, but most of these are using that native collagen now. What they ask is because the action is a little bit different. Type 2 collagen acts on immune pathway. This is a different pathway. So what the doctor may asking, if you combine peptides along with native collagen, we may get more synergetic effect. He may asking that question.
So what's your take on that?
That I think Andrea can answer better.
Andrea,
yeah,
at molecular level.
Actually, the combination of both molecules has this synergetic effect because they act in a different way. One, it's recognized, and the other has the effect directly in the cartilage. So the combination is feasible, and we suggest that it's fine.
So we get a two-pronged approach by combining the peptides and
Type 2 collagen.
yeah, the type 2 collagen.
Yes.
So we are approaching from two different directions, and it is believed they will have synergistic effect and would be helpful.
Yeah,
Yes.
both have effect, but one has this immune tolerated
Toleration, yes. Yes.
the oral tolerance, and the other no. But both act in the same place. Yeah.
Coming back to you, Dr. Reddy,
Yeah.
we about a fortnight ago or so, we had a very interesting discussion on something which is known as metabolic osteoarthritis.
Yes.
Yeah, well, we always know the patient characteristics which are typically associated and which lead to osteoarthritis. Yes, we expect them to have certain issues, but one of the intriguing things which came across and which really make me think about it is we are getting patients who are leaner and not heavy. Right. So BMI is not really,
Right.
going out of place. It's more or less normal kind of individuals. Little bit of paunch, so the abdominal, a little bit of abdominal obesity. And yes, they are experiencing, and a whole lot of these patients are coming with symptoms of osteoarthritis. So one, is that so in your practice as well? And that is what the situation is. That's number one. Number two is, are these the patients you will be looking at as a candidate for reflex?
Yes. There is no limitation of use of this knee flex either for metabolic osteoarthritis or non-metabolic osteoarthritis or high BMI patients or low BMI patients. High BMI, definitely it is significantly proven. It is one of the risk factor for osteoarthritis, high BMI. That as you all know that if we are a biped, we walk with only one single leg, 7 to 10 times of the body weight goes through the knee joint. So if you have overweight, you will have more wear and tear. But we have seen the other cohort patients with the lean patients, thin patients, still they got an osteoarthritis. In that conditions, they have other genetical factors may occur. Arthritis, you can get a genetic factor is a major role also there. And second thing is they abuse the knee joint. For example, they play a lot of contact sports during their childhood time, or they have done some up and down the stairs, agriculture, they have a lot of squatting or carpenters or tile layers, they always on squat. So the lot of forces generates across the patellofemoral joint and tibiofemoral joint that damages the cartilage, or also physical damage. For example, any trauma, they neglect it. Any ligamentous injuries like ACL, PCL, or MCL, LCL injuries, or meniscal tears, they won't seek the advice. If ACL tear, they're okay, but constant micromotion will damage the cartilage. These cohort patients, we have used for both type of patients. I have used especially 40s, they have a ligament injury in the past, but they didn't have any treatment for that. They land up with the osteoarthritis. So in the past, ACL injuries only we used to repair 20 years back. ACL reconstruction was given option only for elite athletics. But now, even if it is a sedentary life, young man with ACL tear, we are offering the reconstruction. Why? Because to prevent the secondary arthritis. So this second cohort is due to these type of things. So we are giving the medication for both cohort type of patients, both high BMI patients, low BMI patients with arthritis were not suitable for knee replacement at that situation.
That's so interesting. So actually, one of your colleagues has asked, where does it stand? I think where does knee flex stand in the algorithm of osteoarthritis? But I think you have made it clear that it's everywhere.
Yes.
Yeah.
Suppose 40 male with arthritis, it's not indicated knee replacement at 40-year-old unless it is absolute stiffness, not able to walk, not able to stand, no ADLs, activity of daily life, then you can do a knee replacement. But is okay, manageable, okay pain, is no point in doing a knee replacement at 40-year-old male. But at the same time, we can't bombard with the NSAIDs for the rest of the 10, 15 years. So these type of medications will help, definitely will help.
Andrea, you wanted to add something?
No, I completely agree with Dr. Yeah.
Yeah. So, are there any other questions, ladies and gentlemen? We have Dr. Reddy with us. We have Andrea with us. So, which you would like to put across or have them answered? I'm not getting any more here. I think I have run out of the questions. What I understand is, irrespective of the stage of the disease, you know,
Yes.
yeah, the knee flex is the choice of the treatment,
Yes.
right? It can be used as a single entity. It can be combined with analgesics or NSAIDs. And even later on, it may help us delay the need for surgery and replacement. That is what I have understood. It is efficacious. And yes, there would be a few patients who may not get benefited, but then that is the beauty of the modern medicine, and that's why we do research, because 100% patients do not respond to every drug. And in Dr. Reddy's experience, 80% or thereof is the success rate, which is an extremely high success rate. I must say that. So with these words, and he has already emphasized on the safety, there have not been many side effects which have been there and which could lead to this discontinuation or which warrant addressing. So it's a fairly safe and efficacious combination, both in the individuals with low BMI as well as the high BMI, which is the classical type with osteoarthritis. So that is what sums it up for today's discussion. Dr. Reddy, if I have missed out on something which you would like to elaborate or add on?
Yeah, only thing, it's selective patients for knee flex. It is not end treatment. I told you it is helpful in arrest this progress of the disease, and we can buy the time. If the patient comes with a severe osteoarthritis with no movements, as indication for surgery. But in the borderline cases, whatever the respect of osteoarthritic changes, young patients, especially young cohorts, this plays a major role. Even elderly patients, if they are not willing for surgery, if they want only the painkillers, this is an alternative for them. That is the thing.
Yeah. Andrea, you wanted to say something?
Yeah, I just wanted to remark that the long-term usage of a native type 2 collagen and also mobility help both in cartilage degradation and also in subchondral bone loss. So we will recommend the continuous use in all osteoarthritic patients, and it can help to avoid the total knee replacement. So we really suggest, if you are under Kellgren and Lawrence grade 2 and 3, to take these kind of products.
One question before we close it. Somebody has asked about gluten-free aspect of the formulation. You would like to speak? Yes, I see you, Andrea, trying to speak and latch on to that question. Yes, go ahead, please.
Please, can you repeat the question? What
They have asked about whether the things are gluten-free, the formulation, the knee flex, or the patients with that kind of allergy, can they use it? Gluten.
Sorry?
Gluten, you know about gluten?
Yeah, no, it's gluten-free. So it doesn't contain allergens. It's only if you have any kind of avoidance of any meat, special meat, or any kind of excipient, you have to check, but it's completely safe. Yeah, no gluten, no traces of any kind of products.
Okay, that's only during the meeting. Okay, so I think we have we have come to the end. Whatever were the questions, we have taken them. And with this, I would like to thank both Dr. Reddy and Andrea for taking out time close to a weekend and almost a weekend. Dr. Reddy especially. So thank you so very much for enlightening us.
Thank you. Thank you for giving this.
Your experience and your knowledge. And I hope all of us have gained from it. Thank you so very much, sir.
Thank you.
Thank you very much. Thank you. A pleasure.
Yeah.
Thank you.
So, ladies and gentlemen, I return you to the studio of OrthoTV and have a great weekend. Thank you so very much for listening to us.
Thank you. Bye-bye.